Welcome everyone to Take Charge for February of 2015. Our topic tonight is high intensity interval training versus a type of training called MICE training, or moderate intensity continuous exercise. For the longest time, cardiac patients all over the world have been focusing on this MICE style of training. We know it's very effective. It provides tons and tons of benefits, and that's why we've done it for so long. Athletes, on the other hand, for many, many years, have been training via HIIT training. We know that it provides greater benefits for cardiovascular fitness, but we always thought it wasn't maybe the safest thing for heart patients. It was too hard to do. Well, there's a growing body of evidence showing that that might not be the case. It might be appropriate for heart patients to participate in this higher intensity interval training. So that's going to be our topic today. Our speaker is Dr. Jim McKinney. Dr. McKinney is a cardiologist who's doing a fellowship with us here at Toronto Rehab for a year. He got his master's at the University of Western. He went to med school at University of Toronto, internal medicine degree and cardiology degree out in BC in Vancouver. He's also got a good interest in sports cardiology, which is fantastic, and I put him through his paces every lunch hour to make sure he stays honest as well. Folks, this is Dr. Jim McKinney. Thank you.
Thanks, Rob. I should just let Rob give the talk. Most of you are patients, correct? So I've tried to direct the talk to make it general enough and that it's not too complex, but the message gets across. I'm not a HIIT expert by any means, even though Rob puts me through my paces at lunch. But I've done some reading about the topic extensively, and I'll share my thoughts and let you guys make your decision at the end of the talk. So does anyone know what this is? So more specifically, so this is the solar system, how we used to think of it before this person. So this is Copernicus. So before Copernicus in 1500, we thought that the Earth was the center of the universe. The sun revolved around the Earth. He wrote this book about revolutions of spheres and published it politically correctly to get it into society without being banished from the church, and change the way we thought about ourselves and the world. So this was his map. Sun is now at the center of the Earth, is center of the universe as opposed to or solar system as opposed to the Earth being. This is Toronto's map of the solar system. So let's just change gears for a moment and get into the talk. So heart failure has many definitions. You can look up in a textbook and you'll see a multitude of definitions, but essentially it's the heart's inability to meet the metabolic demands of the body. And when you can't do that, you get symptoms. So you're either shortness of breath, fatigue, weakness, because you can't meet the metabolic demands that your body wants. Another way to think of it is the heart's inability to pump blood forward to the body, the muscles that are using it, or the heart's ability to pump blood forward, but in order to pump that blood, there are very high pressures in the heart and lungs. So the most common cause everyone thinks is what we call now HFrEF, or heart failure with reduced ejection fraction. This is the case where your pumping function is not as strong as it once was, and that's what we used to think of at all cases of heart failure. However, in an equal proportion now, we recognize that there's heart failure where you can still squeeze the blood out of the heart at a normal strength, but you do so at a much higher pressure, and these hearts are stiff. We call this diastolic dysfunction, or diastolic heart failure, or heart failure with preserved ejection fraction, or HFpEF. If you have HFrEF, reduced function, a weak heart, invariably you have a heart that has a tough time relaxing. The stereotypical patient is typically an older woman with hypertensive heart disease, more likely to have atrial fibrillation, less likely to have coronary artery disease. How do we define exercise intolerance? It's the reduced ability to perform activities that involve large muscle groups before the onset of symptoms of fatigue or shortness of breath. And many of you may have experienced these symptoms. And this is what we refer to as exercise intolerance. So I'm going to ask you some questions throughout the talk. No one has to raise their hand. If anyone does want to raise their hand or shout the answer, you won't be on TV. We can just, if not, it's just a rhetorical question. I'll ask it to myself. The role of exercise in heart failure, is it recommended? Yes, this is an easy question. So these are the 2013 guidelines, but published in 2014. Heart failure update guidelines on heart failure with rehabilitation and exercise, and the other half of the guideline is on revascularization. But they give a strong recommendation. So we recommend that all patients with NYHA class 1 to 3 be considered for enrollment in supervised tailored exercise training program to improve exercise tolerance and quality of life. Strong recommendation. Yeah.
Try and talk a little louder. The fans over here as well.
Okay. No.
I can't turn them off.
So exercise in heart failure. At one point in time, it was contraindicated. So if you had heart failure, no exercise. You just sit. We've smartened up. It's taken a long time, but we now prescribe exercise, and we recommend that it's at a moderate intensity. So not so hard that you're short of breath, but not so light that you're not really exercising. At a moderate intensity, set it and forget it, 30 minutes, that's what you do. That's their current recommendations. This is just essentially what I just said in terms of the technical components of the training aspect. So these are clinically proven benefits of exercise in heart failure patients. So you increase your exercise capacity, you increase your skeletal and respiratory muscle function, your quality of life improves, autonomic function improves, biomarkers improve. These are kind of blood tests we use to measure how much stress the heart is under. And it's been shown to reduce depressive symptoms and, in general, cardiovascular risk factors, high blood pressure, high cholesterol, fasting glucose problems. So VO2 and exercise. If you're a patient here, you've had that scuba mask placed on your mouth, and you breathe into that tube, it's measuring the oxygen that you take in and the carbon dioxide that you put out. This athlete's on a bike, and she's cycling away. And VO2 is what we consider the gold standard for measuring aerobic capacity. It's essentially the body's ability, primarily the lungs and the heart, to take oxygen from the environment, pump it through the heart, through the body, and deliver it to the tissues. VO2 is the gold standard for how we measure aerobic capacity or someone's fitness. But who cares? VO2, whatever. This is why we care. So this is 12,000 patients from this institute when it was formed many years ago, with over 30 years of follow-up data, which is unheard of when you do trials. Most times you do a trial for 5 years, and then when the trial is over, you only know what's happened in the last 5 years. This is 30 years of data. What you look at on the it's wanting me to join my so what you're looking at is the straight line. It doesn't project that well, but the straight line is the one on the bottom, and that recommends that's a VO2 of less than 15. The kind of larger broken line is right at the top. That is a VO2 over 22, so it's a good VO2. And what it shows is it's a function of survival. The higher your VO2 is, the longer you are going to live. The shorter your VO2 is, the less you're going to live.
I wonder why they never gave us that number when they gave us the test.
So why is cardiac rehab effective? And primarily, there's a whole bunch of reasons, but a lot of the reasons come down to a person's ability to increase their aerobic capacity or their VO2. You increase your VO2, your mortality goes down, and cardiovascular events go down.
How do you really define VO2? Is that number? Give us a number.
We'll get to that. So it's a very strong predictor with mortality. The higher your VO2, the better you're going to do in the long term. So VO2, what is it? It's the milliliters of oxygen. Oxygen is a gas, but the liquid in the body, dissolved per kilogram of body weight. So it's indexed per body weight. VO2 is kind of confusing. They came up with this term metabolic equivalence. One metabolic equivalent is you being in a coma. You're not moving, you're not blinking your eyes. It's the amount of oxygen your body needs to survive. So 7 METs, 7 times 3.5 is 24.5. So to your question, VO2 is dependent on sex, age, and weight. So we don't have a cutoff, but when you stratify people based on numbers, in that paper, they just chose 15 and 22 as cutoff points. But we know that, for example, if you do a stress test and you achieve 10 METs or a VO2 of 35, your outcome is just as good as someone who has bypass surgery. But if you have those blockages, you probably need bypass surgery to have that outcome. But VO2 is tightly linked with good outcome, the higher your VO2. This is an example of activities in VO2. So to sleep, it takes no energy at all. 1 MET. Watching TV, 1 MET. Writing a letter, if anyone writes letters anymore, 1.8 METs. Bicycling with light effort, 3 METs. Jogging, 7 METs. So the more vigorous activity you're doing, the more METs or metabolic equivalents you're doing. That means the amount of oxygen you're dissolving into your body, muscles are using it, your aerobic capacity. So this is the take-home type message. For every 1 MET increase, so if you go from 5 METs to 6 METs, you have a 13% decrease in all-cause mortality. This is mortality from every cause. Heart disease, cancer, stroke. You decrease your cardiovascular events, heart attack, stroke, cardiovascular death by 15%. So this is why we get all excited about VO2 and METs. So high VO2, low death. And these are in population studies of hundreds of thousands of patients. This is not a study of 20 patients. This is looking at large populations, looking at their VO2 and seeing what they do 20 years later. How many people are alive and how many people have passed away. So the question becomes, since VO2 is so important, is there a better way to increase VO2? Traditional cardiac rehab, so this is the program most people in this room have done, is either walking or cycling at a moderate intensity. We use the VO2 calculation or the heart rate calculation. RPE is rate of perceived exertion. When you guys were on the treadmill and they had that scale from 6 to 20, they would ask you, what are you feeling right now? And you're like, well, it's somewhat hard, I'll give it a 10. And 5 minutes later, you're like, oh, it's really hard, I'll give it a 16. So you can use that as a measure of your intensity. 20 is you cannot do anything more. 6 is you're just resting. Exercise time, we'll just quickly go over this, is not super important. Recommendations, 150 minutes a week. Most people do not get that. When you look at population studies, people who have cardiac disease or do not cardiac disease, we're a very inactive society. So is traditional cardiac rehab effective at increasing VO2? Most people in this room probably, hopefully, will have the first test and their last test, and they've seen that their VO2 has gone up somewhat. So the answer is obviously yes. This is a look at studies from the 1990s. Just a list, don't have to worry about it. On the right side of the screen is the percent VO2 increase, so 20%, 18%. So if you think of the average as 20%, if you start off with your VO2 of 10, 20% go up 2, so you're almost increased a half of MET. So 20% is not too bad. This is traditional cardiac rehab, all the cardiac rehab that you have undergone in this room. Some people who are against cardiac rehab, even though there's a mountain of evidence for it, they will point to a randomized controlled trial called HF Action. This is really the only large randomized multi-center trial that looks at cardiac rehab and all-cause mortality and hospitalization. The trial was what we call negative, so it did not show a result that suggested going to cardiac rehab in this trial meant that you lived longer. However, I'll just spend a couple minutes. There are a lot of problems with this trial. Just 2 slides and we'll go on. They had a very poor exercise training adherence. So when they looked, after the trial was done, all the investigators look at everyone's journals and charts, and very few people actually did the recommended exercise. So only 30 to 40% of people were following the training recommendations at 3 months. So if you're not really doing the intervention, it's tough to say that intervention is ineffective if 60% of the people aren't doing it. Furthermore, there is what we call crossover in trials, and this happens in a lot of clinical trials, is that the placebo group knows they're being the placebo group. If you're taking a pill, it's easier because you don't know if the pill is real or the real pill or the fake pill, the placebo pill. But in exercise, you kind of know if you're exercising or not. And you know, these people that were randomized to the non-exercising arm aren't getting the benefits of Rob and everyone. So they're like, I'm going to start exercising myself because everyone's telling me I should exercise. So these people who are not supposed to be exercising cross over. They start exercising. So they're actually looking better than they actually probably are. The change in the exercise group was very modest, only 0.6. Small change, only a 14 or 4.2% difference, so a tiny change. So the exercise that the people were doing, very tiny change. So it's not surprising there wasn't a positive result. That being said, when they adjusted for these confounding variables, it showed a decrease in all-cause death or hospitalization by 11%, which is pretty good. If that was a pill, it would be the #1 selling pill on the market to get 11% reduction. This is the evidence for traditional cardiac rehab, all cardiac rehab. So initially, cardiac rehab started for patients with coronary artery disease. Now it's expanded into heart failure and stroke and cancer and a whole bunch of other disease states. But if you take everyone and put them together, you decrease your mortality by 20%. You decrease your cardiac mortality by 26%. Your chance of having a non-fatal myocardial infarction or a heart attack by 21%. So if these were pills again, it's $1 billion drug for the drug company to have these benefits. Contemporary evidence, so that people will distract and say, well, this is old data. People weren't getting ICDs. They weren't getting drug-eluting stents. They were only getting bare metal stents. So let's look at the new data. So new data from 2011. Mortality still decreased by 13%. Cardiovascular mortality by 26%. And hospitalizations decreased by 31%. Politicians love hospitalizations, because when you go back to the hospital, it costs the government a tremendous amount of money. So if you can decrease hospitalizations, healthcare bodies are they like that outcome, because nowadays to power trials you need so many people to show a difference in mortality, but if you can show a difference in hospitalizations, we think that's a good outcome. So we'll shift gears again. So what exactly is HIIT? High intensity interval training. It's exactly what it says. It's short periods of exercise at a very high intensity, followed by a period of rest. You can either be doing nothing, so you run and then just stand still. That's passive recovery. Or you run and walk very slowly, and then you run again. You walk very slowly, then you run again. Or you're on a bicycle, you cycle really fast, and then just coast. Cycle really fast, and then coast. That's all it is. It's different than the moderate intensity continuous exercise of the mice, which is set it, forget it, go at 60% and just cruise. So HIIT training has been around for a long time. I'll show you some pictures in a moment. This is Jesse Owens. Some people consider him the greatest Olympic athlete ever. HIIT is very effective at increasing your VO2, or your cardiorespiratory performance, and the performance of athletes. That's why athletes use it. When you stress your body near the maximum limits, your VO2 max, or there's no further limit that your body can physiologically take oxygen from the air and deliver it to the muscle, VO2 max, you stress those systems out. And after those systems have stress, they can start to adapt at that high stress.
You don't need to worry about heart rate getting way off the charts.
We'll discuss it. We'll discuss it. So it allows you, so there's no way you could do 100% for 30 minutes. No one in the world could run at 100% for 30 minutes. Usain Bolt could maybe run at 100% for about 45 seconds. It's impossible to go at 100% forever. So, but if you go full out and give yourself a break, then go full out again, give yourself a break, on average, you've pushed your upper limit. You've nudged it. You keep on going along, pushing it. So that's the theory behind HIIT training. I kind of just said this last point as well. The body gets used to and more efficient at that stimulus. So when the body is stimulated 100%, the metabolism in the cells, the muscles change, breathing, the loading conditions of the heart change, and the body adapts to it. The body is very smart, so it starts to adapt to those changes. Now, this is the schematic that I just kind of went through on that little bike acting session. So HIIT, you have a low warm-up at about 30%, and then you go 15, 30, whatever the interval is, seconds, all out, rest. 15, 30 seconds, all out, rest. Whereas mice, or moderate intensity, is just set it and forget it. So if you look at them beside each other, we talked about heart rate. You're going at 85 to 95% of your peak heart rate. So your peak heart rate is 220 minus your age. So if you're 70, your peak heart rate should be around 150. Okay? So you're pushing your heart rate up to about 150. Or your heart rate reserve is a calculation that's a bit better because it's adjusted for resting heart rate and the maximum heart rate you achieve on a test. Or this VO2 reserve, which we get from the gas analysis. Whereas moderate intensity, you're less than 80% of your peak. You're not even close to your peak heart rate. Or you're 40 to 60% of your heart rate reserve, or 40 to 60% of your VO2 reserve. So what defines high intensity? This is kind of just to repeat the slide. Max, a near max heart rate. You're running near your VO2 max. You're running near your heart rate reserve, which is essentially your max heart rate. And your exertion scale, your self-reported scale of effort is very high. Like, you're not faking this one. You're like, this is really hard work. Like, I can't breathe. This is really hard. So it's a really hard. You're really exerting yourself. Does anyone know where this is?
Europe, something like that.
So this is the city of the Super Bowl champions, the New England Patriots. This is in Boston. This is relatively a new. This is in Copley Square. It's a relatively new piece of art, and it's for the Boston Marathon participants. So the Boston Marathon is the most prestigious marathon in the world, and everyone from the world tries to qualify and come there. So it's just a monument in Copley Square to the Boston Marathoners. So is HIIT a cutting-edge new technology? No. So I've kind of prefaced that earlier in the talk. This guy is the first guy, apparently, that formally used HIIT training to win gold medals. I don't want to. He's a Finnish guy. In 1910, he used a method of going really hard, relaxing, going really hard to increase his aerobic capacity. I don't think he knew what he was doing, but it was quite successful. He won 3 gold medals in the 1912 Olympics. It kind of became popular by this guy. If you ever Google HIIT, this guy's name comes up. This is after the World War II. Athletes started catching on to the idea that HIIT training might be helpful for improving aerobic performance. And he won 3 gold medals as well. So these guys are using it to win gold medals. The medical world is thinking, can we use this pattern of training to help increase the VO2, which we know is so tightly linked to mortality? Because if we can increase the VO2 by 3.5 or 1 net, we know we can decrease all-cause mortality by 13%. So why is HIIT specifically well suited for heart failure patients? Because life is not set it and forget it. Life is running upstairs to get something, coming back downstairs, running outside because it's cold outside to get inside. So life is stop and start. And just because you're a heart failure patient and you may not be able to run marathons anymore, doesn't mean you have a life where you want to get up and go and do things. All your activities aren't going to be at a slow pace. They're going to be stopping and starting. So is it recommended by the guidelines? Yes, it's been recommended by the guidelines since 2007. Specifically in the 2013 guidelines, I showed you the title earlier. This is what they recommend for HIIT. So if you're already in a stable, you have to be clinically stable. If you're already in a moderate continuous intensity program, you can consider doing 15 to 30 second intervals of HIIT training with rest for 15 to 30 minutes. So this is the recommendation from 2013 by the Canadians. Specific recommendations for HIIT therapy. Yeah.
Are atrial fibrillation patients considered stable in this context?
Good question. So we consider atrial fibrillation stable if your resting heart rate is less than 100. That's the goal resting heart rate. But many patients would be with atrial fibrillation will be heart failure patients.
And is there any reason why you wouldn't augment this with weight training or maybe not heavy weights like bodybuilding, but just tone and reps and stuff like that they have in the gym here?
I suppose I haven't really read anything about that.
I mean, you do both.
It would be,
This seems to be more cardio.
yeah, this is more cardio. If you needed an extra stimulus to push your limits that high, then I guess you could, but typically most heart failure patients wouldn't need extra weights to push the limits. So does intensity even matter? And I'm answering the question for us. Yes, it does. There's a Copenhagen heart study, genius study, I think it was formed in the 70s. And they essentially just asked the people of Copenhagen, do you want to come in? We'll check your blood pressure, we'll check your cholesterol, fill out some surveys, and we'll see what happens. So they have an excellent system in Denmark. Every time you take aspirin from a pharmacy, it's tracked. If you die of stroke, it's recorded. They have an amazing database. It's a small country. So they have, it's the Copenhagen Heart Study. And so now, 20, 30 years later, you have all this data for 30 years of follow-up. So they had 5,000 patients, 21 to 90 years old. And these patients were all cyclists. If everyone's been to Denmark or Holland, everyone has a bicycle. And they asked, you know, how much cycling do you do? Half hour, hour to an hour, or greater than an hour on a day. And they asked self-reported. So this is not heart rate measured. Self-reported, how intense do you bike? Do you just kind of diddy-daddle, or do you like bike really hard? So this is a self-reported. And what they found was intensity is exceedingly important. These are just cyclists, random people who are apparently healthy. And those who self-reported they were bicycle intensing and at high intensity lived on average 5.3 years longer. That's huge. The duration, it didn't really change that much. The people that were biking over an hour a day, you know, it didn't really do much at all. And this is the same effect, the lesser degrees was found in women. So the duration of activity wasn't a strong predictor of if you're going to live or die. It was the self-reported intensity, which is an interesting finding. So is mice better than HIIT? So anyone who's known this story knows the tortoise wins the race, right? Slow and steady. Did I ruin it? And then the rabbit was sleeping and loses the race, or the hare. But so let's answer this question. So this is a study from 2007 out of Norway. The Europeans are miles ahead of the Americans and Canadians in terms of exercise prescription, active lifestyles. And anyone who's traveled to Europe will know this. Everyone walks everywhere or takes a bike. You can't just drive to a mega mall in Europe. You know, there's no big box stores. So this is the abstract. I'll just go through it. I highlighted the key features. We'll just kind of dive into this paper a bit. So they know that exercise is good for heart failure, because we've known that for a long time. They took 27 patients, everyone who's had a heart attack, and the heart attack caused some of the muscle to be damaged, and they were left with a weaker pump muscle. They all had heart failure, and then they said, let's take 27 patients, not very many, let's take 9 and do nothing. We'll take 9 and say, you do the continuous set it and forget it, moderate intensity continuous exercise bit that we know and we love. And we'll take the other 9 and say, let's do some high interval training. So this is anyone on ticagrelor? I imagine a lot of people are. Ticagrelor is a new Plavix. It's a new antiplatelet medication. This is the Plato trial. If you add up 9333, 99291 at the bottom, that's 18,000 patients. And we're talking about 27. So it's a difference. Cardiology trials we're used to seeing 20,000 patients. So this is only 27 patients. So you just got to keep that in mind. This is the comparison of the 3 groups. They all had excellent medical therapy. If you have heart failure, you have to be on a beta blocker. You have to be on an ACE inhibitor. If you're on a statin, would make sense if you have coronary artery disease, aspirin if you have coronary artery disease. So these people had excellent medical therapy. They're all 75 average, 75.5, 74, no significance. So table 1s and papers are shown to show that the groups are equal going into the study. Because the groups are different when they go in, they're going to be different when they come out. So you randomize people so you get equal number of comorbidities or covariables that might have an effect, so they're distributed across all 3 groups. So this was an aggressive trial. This is in 2007. So they warmed everyone up, and then they did 4 minutes of going at 90 to 95% of your peak heart rate, which is crazy. Like, very hard. That's very, Rob cannot do that. And then they had a 3-minute break where they just slowly walked. And then in the, so they did 30 minutes of total activity. In the moderate group, they just walked at 70% of their peak heart rate for 47 minutes. The difference in minutes, 31 to 47 minutes, here and here, is, or 38, sorry, to 47. They measured the calories to make sure that it wasn't a calorie effect. So the moderate continuous group had to walk 9 minutes longer to make sure they had equal calories between the groups. And so this is what they found. So their baseline VO2s were 13. If you look at the control group, that's the first group, they did nothing. There was no exercise at all. They went from 13 to 13. In the moderate continuous activity group, or the MICE group, they had a reasonable benefit, 13 to 14.9. So an increase of 1 point, or almost 2, which is pretty good. In the high intensity group that were like stressing them for 4 minutes at a time, their VO2 jumped by 6. So that's almost 2 METs. Remember, a MET is 3.5. So that's a huge difference. If you look at the bottom, we talked about rate of perceived exertion, the Borg scale, the same thing you get when you're doing your stress tests downstairs and they point to the number how difficult it is. Obviously, the people that were sitting on their ass doing nothing had self-reported. No. The 12 comes from their exercise that got these numbers. The moderate continuous exercise, the MICE, no real change, but the people that did the high intensity, they were working hard. 17 out of 20 is very hard. They were giving it. So we'll change gears slightly again. This is the left ventricle. Cardiologists mostly care about the left ventricle because the left ventricle, it takes blood from the lungs and it pumps it to the body. And most of the interventions and things we know, it's all about the left ventricle. The right ventricle is important, but we forget about it. But we love the left ventricle. So does anyone know what an ejection fraction is? Do you guys know that? So I'll explain it for people that don't know. Before we go, I'll ask you this question, I'll come back to it. What is a normal ejection fraction? So in high school, if you got 90%, it was excellent. If you got 70%, it was okay. So what is a normal ejection fraction? Normal.
How many people think it's 8? 60.
So I heard 60, that's excellent. Rob taught you guys something. So what does that mean? Go back to here. So it means that for every heartbeat, 60% of the blood when the heart gets filled, just before it's about to contract, the heart is full of blood. When it contracts, 60% of the blood will go forward, 40% will stay behind. No one's 100%. No one gets 100% out. When you're exercising full out, you may get 75, 80% ejection fraction. So it's not like in high school where 90% is good and 60% is bad. 60% is good. That is normal. Ejection fraction 60%. So it's the amount of the volume, amount of blood going forward divided by the total amount of blood before the heart contracts, the end diastolic volume. And we love this ejection fraction. So I'll ask you guys which ones are normal. I know you guys aren't cardiologists, but you'll figure this one out, hopefully. This is, if anyone has had an angiogram done, this is the test where they warn you. You might feel like you're going to wet yourself. You'll feel warm flush through your body. This is the test. So which one do you think is normal? I just told you guys ejection fraction is the blood going forward over the total blood. Anyone? Yeah, the video won't loop. So the one on your left is normal. So if you look at it, it fills, and a lot of it, more than 50% of the blood, or that dark contrast that gets ejected through your body, it goes out of the ventricle and up into the aorta. In contrast, this guy or woman on the right, the heart walls aren't moving that much. The dye is just hanging out. This ejection fraction is horribly poor. I'd say in the range of 20%. Then you can't. It's tough to tell. It takes you a while. But this person's had an anterior infarction. The anterior wall is not moving. But why is ejection fraction important? Well, it's essentially based on this study and a large number of natural history studies showing that ejection fraction is closely linked to mortality. This is an old trial that's small, only 196 patients. That's not a lot of patients for a trial, from 1992. This is before a lot of people have excellent therapies such as beta blockers and ACE inhibitors and spironolactone or eplerenone on board. But they looked at people that had a heart attack, and they looked at their ejection fraction after the heart attack and looked at mortality. So you can see, even if your ejection fraction goes from 60 to 45, not a huge deal. But once you drop below 35, it really spikes. Your cardiac mortality starts to go really high. You go less than 30%, your cardiac mortality in this study is almost 50%. It's not as bad nowadays because of medical therapies. We use the ejection fraction if anyone has an ICD in, or CRT or BiV pacemaker. We use that because when you get around 35 to 30%, your risks not only of dying of the heart pump not pumping work, but dying of an electrical arrhythmia increase. So once you drop below 40%, the events of pump failure and electrical problems start to rise significantly. This is I showed you a moving picture just recently. Which one do you think is the best one? Which one would you want to have, A, B, or C? This is the left ventricle, a schematic, just a cartoon.
C?
No, B.
So, bigger is not always better. The answer is A. And C was once A, but due to an insult in what we call negative remodeling, it's now a baggy ventricle. Ventricles are shaped like an ellipsoid or a bullet. That's the most efficient way to eject fluid out of a container. Like the giraffe's heart is a giant ellipsoid because it has to eject blood 20 feet into the air. It's the most efficient. When you change the dynamics or the geometry into a ball, it just becomes a bag of not too efficient. Yeah.
Excuse me. I sort of went to the speaker series yesterday. They had similar talk. isn't A really showing a thicker wall, meaning a stiff, versus B, which is doesn't, because the stiff wall is the
that is a good point. If this if I had a scale, you would say yes. This could, if A could say hypertensive heart disease and diastolic dysfunction. B is the in between going from A to B. B, this patient had a heart attack and now they've negatively remodeled. But in a different example, you could say that B is right and C is hypertensive heart disease. So you were paying attention yesterday, that's good. So what is LV remodeling? This is what we use medications to counteract. Beta blockers and ACE inhibitors. Even though I'm a very big proponent of exercise, I would never tell someone to stop your beta blocker and ACE inhibitor in the favor of exercise. I would say take your beta blocker and ACE inhibitor for a run, and then after you get home, have your pills. Because they're exceedingly important. The beta blocker and ACE inhibitor decrease mortality and decrease hospitalizations, and they prevent this negative remodeling. When you have an injury such as a heart attack, you have a scar that develops, and that part of the heart is not moving. It's not contracting as well as it should be. If you're in a dark alley and you're confronted by a mugger, there's the sympathetic nervous system, the fight or flight. Your hairs on the back of your neck raise, your pupils dilate, your heart rate goes, and you're ready to run away. In the acute situations, that will save your life. But chronically, having that system constantly going, it leads to negative remodeling, increase in bad hormones in the body, increased arrhythmias, increased blood pressure, increased heart rate. So beta blockers are paramount at blocking that high level of activity. There were 3 trials that were released. They had 34, 34, and 35% reduction in the primary endpoint. So same, like irrefutable evidence. And there were about 20,000 patients in each trial. So beta blockers are exceedingly important. This is a video of LV remodeling. So it's a nice narrow heart at first. And it starts to dilate, dilate, dilate. The ejection fraction has gone down. And now it's a kind of a baggy ventricle. Okay. This is someone who's had a myocardial infarction. After the heart attack 1 week later, the ejection fraction was okay, 41%, not too bad. I don't know what happened to this patient. Maybe they stopped their pills. I don't know what's happened. But they come back 3 months later, and the ventricle, even though the original HIIT only took away 20% of that 60%, the negative remodeling caused the ventricle to dilate in a bad way that made it inefficient to pump blood. So now the ejection fraction has dropped to 23%. This is an echocardiogram. I don't know if you can see that well at all. Anyways, the one on the left is the good one. This is on the side chamber. All the walls are coming in nicely. These walls have wall motion abnormalities. Not nice. So I don't know if you guys have seen your own echoes before. If you've seen an echo, this is what an echo looks like. This is the ultrasound of the heart. They put the jelly on the body, and then sometimes they'll make some sounds. Makes sounds like a baby ultrasound. So why is remodeling bad? It makes your pump function worse. Your EF that was 40 is now 23%. Now you go from not needing an ICD to needing an ICD. So LV remodeling is bad. Increases the wall stress. Don't worry about that. It essentially means makes the heart's ability to work harder. Increases the oxygen demand of the heart. For the heart to do its work, it needs more oxygen. The myocytes don't work as well. The electrical system may become dysfunctional. Some people might have the fancy CRT or BiV pacemaker. That helps correct the abnormal electrical function of the heart. You have more mitral regurgitation. more ventricular arrhythmias, and it can lead to death. So remodeling is bad. So back to the study of the 9 patients. So we'll go through it here. Their ejection fraction was 26% in the control. They did no exercise, the ejection fraction remained the same. That's the one. I'll direct your attention to the bottom. If you look at the high intensity group, they started at 28%. Those 9 patients increased their ejection fraction to 38% with the high intensity exercise. Stroke volume is as we said earlier, stroke volume over end diastolic volume is how we measure ejection fraction. It improves. So with the high intensity exercise, we get more blood out forward. And as we said, bigger is not always better. The heart size decreased. So they went from 66 to 59. So these are all amazing things. You had reverse remodeling. Instead of having negative remodeling, the heart started to look more like a heart and less like a bag. So conclusions from this small randomized controlled trial. Reversal of LV modeling, that got people really excited. You increase your aerobic capacity. The endothelial function, don't worry about that. And their quality of life measure they used in the study improved. So the patients were happy, they had better quality of life. True or false, high intensity, the animation didn't work here. The high intensity interval training is associated with hemodynamic instability. What I mean by that is that your blood pressure is going really high and it's going really low and you're gonna pass out, and it goes really high and it goes really low and you're gonna pass out. So they looked at this. This is a study from Montreal Heart Institute. 13 patients, age 60 years old. Their ejection fractions were 27%. They had randomized to high intensity training or continuous exercise. And there was no difference in their hemodynamic outcomes. So cardiac output was the same. Stroke volume was the same. The total vascular resistance, stroke volume times total vascular resistance is your blood pressure. No difference. So hemodynamically, the people that were walking continuously at 70% had the same hemodynamics as the people that were going hard for 15 to 30 seconds and resting. And there's no significant difference in arrhythmias or abnormal blood pressure in this trial. This is the map of the blood pressure, this is the map of the cardiac output over time. The top one is actually the continuous and the bottom one is the high intensity. So the stroke volume, the cardiac output, relatively stable in both groups. So you're not having crashes in your cardiac output during this activity. So is high intensity interval training more effective than continuous? So we have some recent evidence in healthy participants. This is like, when I say recent, I mean 70s and 60s and 80s. If you took college students who needed money and ran them on a treadmill, you can increase their VO2 this way. Increases in heart failure patients, increase in VO2 in heart failure patients, coronary disease, there's a lot of evidence for coronary disease as well. Switch gears a bit. So on the left is the Speedmaster watch. This is the only watch that's ever been on the moon. On the right is Kairos. So I saw a lecture when I was in internal medicine. I would work 48 hours in a row and go home to see my kids and be exceedingly tired. I saw this lecture on time. So the Greeks had 2 words for time. Chronos, which is just quantity of time, 8 seconds. And Kairos, which was more representative of quality time. The time that you enjoy, as opposed to Kairos also means weather, but is the quality time. So we are fixated on quantity of time in trials, making people live longer, or total mortality, decreasing death. but we shouldn't forget about the fact about quality time. So making people maybe not live longer, but live better. So the question becomes, does HIIT improve quality of life? If you have heart failure, or you know someone that has heart failure, you don't need to be told that heart failure affects your quality of life. You're not able to do the things that you were able to do previously, and primarily because you're limited by your heart's inability to keep up with your metabolic demand. Independently, when we see something that says independently, that means they control for all the other risk factors. Low quality of life is associated with the increased risk of dying. So this is from 2014. They took patients with heart failure, they gave them HIIT training, and they showed significant results. So in the top line, MLFQ is Minnesota Living with Heart Failure Questionnaire. It's a validated questionnaire used in heart failure patients to assess quality of life. A high score is bad, a low score is good. They went from 21 to 7, so a huge difference, positive difference in their quality of life, 66% reduction. And the reason for this improvement was that they had a significant improvement in their aerobic capacity. So remember, life is not continuous, it's stop, start, stop, start. And they were able to do their activities that they'd like to do, or get around the house and just do basic activities that were essential to their living and their importance of life. And obviously they felt better. Strength of evidence, we'll just go this quickly. Having a randomized controlled trial is when you try to take an intervention and see if that intervention is effective. But you have a population that is randomized, that gets, some people get the intervention and some people don't. The reason you do this is because people might have covariables that might affect the outcome. For example, if you live in a large town, there is more likely to be prostitutes. Yeah. But if the more churches there are in a town, the more likely there's prostitutes. It doesn't mean that religion's causing prostitution. It just means that the more churches there are in a town, the bigger the town, the more people there are that frequent prostitutes. So you try to cross out these variables, and to make sure that both groups are equal. If you take a number of randomized controlled trials and put them together, that's a meta-analysis or a systematic review. That's the best. That's the best level of evidence we have. So here's a meta-analysis in JACC. JACC is an extremely good journal from 2013. It looked at some trials. It showed that peak VO2 increases in high-intensity training versus continuous moderate training. This is a systematic review from 2015 of 11 randomized controlled trials. And I'll just jump to, these are some of the protocols they use. You don't need to know this. But these are the benefits of high-intensity training. So increased aerobic capacity, that's the increasing the VO2, high VO2, low death. Increased anaerobic threshold, that's related to the VO2 thing. Can make the heart myocytes pump more efficiently, increase your ejection fraction. It attenuates when the cell is injured, the heart will kind of grow in a bad way. It attenuates this bad growth of the heart muscle. It decreases the stress of the heart that it's undergoing. As I showed earlier, the heart becomes less like a bag and more like the bullet it was meant to be. So it becomes reverse remodeling. The heart function increases, the ejection fraction increases, the endothelial function improves, and quality of life improves. I'll just kind of skip over this. What's the ultimate protocol? These guys from Laval took 20 patients. They all had heart failure. They were all men. I don't know why they chose all men. They put them through 4 different protocols, and they saw which one's the best. Turns out this is protocol A. I'll skip through this. This is kind of monotonous. It's not too important. And they found that with this protocol A that you had more time in exercise, so you exercise longer. So that's 30 seconds running, 30 seconds rest. It was actually done on a bicycle. 30 seconds hard cycling, 30 seconds rest. If you got close to your VO2 max, so you were pushing your upper limits, you had lower rate of perceived exertion. So they rated their RPE was 15, whereas the other groups were 18, 16, and more of the people completed their exercise protocol. So does high intensity improve adherence to cardiac rehab? The theory is that it's more fun, or it's less monotonous than just setting and forgetting for 30 minutes. And there's a suggestion that HIIT training has more people completing their cardiac rehab. So does that even matter, completion of cardiac rehab? Obviously it does. So the more sessions you attend, this is American data, the more sessions you attend, the lower your mortality. Kind of goes without saying. This is not, so I've painted a pretty rosy picture. You know, soon, this is Philippidis. He's the first documented sudden cardiac death. So he delivered the news of a victory in Greece, and he ran 25 miles from marathon, and then he died at the foot of his superiors delivering this message. And people were shocked because he was the best messenger. So between the town, you had a message, you call out this guy, tell my friend this, he runs 25 miles down the road, tells them, comes back. That was his job. And he died, and he was the best messenger. So everyone was shocked. This is the first death, sudden cardiac death. So true or false? Vigorous exercise can acutely and transiently increase the risk of sudden cardiac death or myocardial infarction. So it's true. But don't panic, like don't run for the doors yet. I love Gary Larson. So it is true that running if you go out for an acute run, you have a slightly increased risk of death or heart attack. However, if you're active, your overall risk of dying is 56 times less likely than someone who's sedentary. So if you're sedentary and you try to do some exercise, your risk of death is 56-fold. Those who exercise on a regular basis, your risk of death is mildly increased. On the right side, it shows the frequency of exercise and the risk of myocardial infarction. So if you don't exercise at all, you have a high risk of 107 times more likely of having a heart attack. If you exercise 5 times a week, your risk of an MI is 2.4 times. So you're protected by exercise. True or false, cardiac rehab is safe. Obviously, this is true. Traditional moderate intensity cardiac rehab, this is the cardiac rehab that we do here. The risk of having a fatal event is about 1 in 750,000 training hours. So if you cross Eglinton Avenue, you're going to get killed more likely than doing cardiac rehab. I'm almost done, Rob. And risk for arrest and death are 1 in 200,000 hours. So it's safe in heart failure populations. We know this. Is HIIT safe in? Yeah, I know I'm running out of time. Is HIIT safe in? Is HIIT safe? True, false, or uncertain? Rob, stop.
Sorry.
So bottom line is, HIIT. They didn't show any arrhythmias. They didn't show normal blood pressure. Troponin is the measure we use to measure heart damage, not increased. BNP measured heart failure, not increased. This is from the Norwegians. They've been doing HIIT for a long time. They had 4,800 patients do their HIIT program. And when they looked at their event rates, they had 2 patients that had a non-fatal cardiac arrest in the high intensity group and 1 patient in the moderate intensity group. So their conclusions was that HIIT was safe and should be considered for future cardiac rehabilitation programs. I told you that RCTs are very important. This RCT, I flashed this very quickly so you would get confused. The title is Much Potential but Many Unanswered Questions. So this RCT is only 200 patients. So of 11 trials, they only added up to 200 patients. Okay? Should we change? This is the last slide. Should we change to HIIT? It does improve your VO2. That is we have pretty solid evidence of that. We know that increased VO2 is associated with less death and less heart attack. There's a small absolute risk of increased cardiac arrest with HIIT training compared to moderate intensity training, but it's 1 in 50,000, like a small increases there, but it's small. Do we have enough evidence? So we have these RCTs and meta-analysis, but it's only really 200 patients. All these trials are small trials, 25, 30 patients. Is that enough evidence to change what we're doing? No study, though, has evaluated the long-term outcome. So these studies are like, we exercise you for 12 weeks, your VO2 increases. We're going to infer that since your VO2 increases, you're going to live longer. But we can't say for that for certain. And that's it.